A.K. Das. He does not need any introduction. And so Dr. Das is presently Professor of Medicine and Professor and Head of the Endocrinology, Pondicherry Institute of Medical Sciences. And he was former Senior Professor of Medicine and Endocrinology, Head of the Department of Endocrinology, Dean, and Medical Superintendent of Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry. So he has taught medicine for a lot of us and our postgraduates in medicine and diabetology for the past 33 years. At any meeting, you can see him with full of energy, waiting to actually give out his knowledge. He wants to share his knowledge to everybody. So he's a member of the Physician Research Foundation of Association of Physicians of India also. So now I request Dr. A.K. Das to deliver his lecture. Thank you.
Thank you, Chairperson. Thank you, Dr. Sadashiv Rao. Thank you profusely for this honor given. So shall I start sharing my screen? Dear friends, I'm going to speak on a topic which is very important, of paramount importance of today. And this is about, I call it most important contemporary topic, the legacy effect in type 2 diabetes. Dear friends, I have got for this slide as I have to discuss the topic. I have brought for you a very brief agenda. We'll discuss first what is legacy effect. What are the evidences for legacy effect in the type 1 diabetes and legacy effect in the type 2 diabetes, and what we do to get this legacy effect, and we'll see that what are the mechanism, cellular, molecular basis of this legacy effect, and where legacy effect may not be found. But most important, legacy effect is there, but so what? What we should do to reap the benefits of the legacy effect? How do we prevent the irremediable diabetic complications, the irreversible diabetic complications, and to give the mortality benefits to our patients? So we'll draw some summary, some conclusions, and some take-home practice points. The legacy effect is a term that describes the continuing benefit. I'll repeat again, the continuing benefit of an earlier period of improved glycemic control. Very simple. Continuing benefit of an earlier period of improved glycemic control. It is seen both in type 2 and type 1. Type 2, we call it legacy effect, and in type 1, we call it metabolic memory. What are the evidences? Dear friends, since it is legacy effect, I will have less emphasis on the type 1 diabetes. Be that as it may, suffices to mention that if you look to the DCCT and the ADIC study, it confirmed the metabolic memory, and you find that once DCCT was over, the conventional and intensive arms were left on their own. You find that even at the end of 6 years, even at the end of 12 years, in the ADIC study, you find that the intensive arm continued to have the benefit of the earlier good control. It said the metabolic control gets ingrained, to use a phraseology, get ingrained into the DNA of the patient, and that provides the benefit. But our focus today on the type 2 legacy effect, UKPDS Glucose trial. Dear friends, it had two arms. The patients randomized to intensive versus conventional glycemic control. The conventional glycemic control, I'll go a little fast, all of us know it, but the lowest fasting plasma glucose attainable, whatever it is, with diet alone. Intensive glycemic control was for fasting plasma glucose less than 0.6, that is about less than 108 milligram per deciliter with monotherapy, and rescue therapy was offered only when it went above 15. And believe me, in the beginning, the UKPDS is only a monotherapy trial. And you know, it gave us two great messages that progressive hyperglycemia does occur, whether you give conventional treatment or the intensive treatment with glibenclamide, chlorpheniramide, insulin, or metformin or combinations. It also said that both in overweight and in non-overweight, there's a progressive hyperglycemia because of the beta cell apoptosis. Two great truths of beta cell loss is 4% per year. I heard to the beautiful talk about de-differentiation by Arvind Gupta and the beautiful questions asked. But dear friend, shown in the first glucose trial for a 10-year study, 1987 to 1997, that there was, by reducing H1C by less than 1.9%, there was any diabetes-related endpoints, there was a benefit of 12%, microvascular disease 25%, retinopathy 21%, albuminuria 33%, and myocardial infarction 16%. To remind the people who have lost this age-old knowledge, it was greatly beneficial. Now, it has been also shown that the meta-analysis of the fatal and non-fatal MI in the Accord, Advance, UKPDS, and BADT trolley. UKPDS have included only the first 5 years, only. It was shown that that if you compare, the intensive glucose control is always favored. But I'm not talking only intensive glucose control. I'm talking intensive control at the onset of diabetes. That is my message today. Now, this trial of 87-97 was extended observation for 30 years, and we'll discuss what is the objective of this trial monitoring. It is still going on to observe the HbA1c level after cessation of the intervention trial, to observe the glucose therapy regimens, to determine the long-term impact of the earlier improved glucose, which had been let loose. I'll use the word let loose after 10 years on the micro and macrovascular complication, and to evaluate the health economics, which is not yet out. 5-year, 20-year intervention trial from 77 to 97 on the 5,000 plus patients with newly diagnosed type 2 diabetes patients. Median follow-up of 10 years presented at the 1998. Results I showed you that 12%, 21%, 23%, 16% benefit of a good control. In the post-trial monitoring for another 10 years, 97 to 2007, it was an annual follow-up, first 5 years by the clinic, next 5 years by questionnaire method. Median overall follow-up was up to 17 years, range 16 to 30 years, and the results presented at the 2008 in the Barcelona EASD. And you will find the post-trial mean H1's level became identical both in the intensive group with sulfonylurea insulin and also in the conventional group. It also showed the therapy also became almost similar. But what was the novel legacy effect? This is shown here. This is the first 10 years, you see the benefits of a good glycemic control. Now, this same benefit was present even a median follow-up of 16.8 years. This was 10 years, this 16.8 years. That is the legacy effect. Now, I have brought here beautiful cartoon to show you, if you look to the any diabetes-related endpoints, 12% risk reduction in the first 20-year study. Legacy effect, it continued after 10 years, so 9% risk reduction. Look at the benefit in the microvascular complications, 25% in the first study of the UKPDS, but in the follow-up study, 24%, almost similar. Now come to the myocardial infarction, you will find it was 16% relative risk reduction in the main study. In the follow-up study, in the legacy effect, 15% reduction. And lo and behold, if you look to the mortality benefits, in the all-cause mortality was 6% relative risk reduction. Here it was 13% relative risk reduction. Sure, yes, I brought this Word document here, where it shows that after median of 8.5 years post follow-up, you find the benefit of everything same, almost same, sometimes little better, but almost similar. Now, this is a beautiful cartoon I like to draw attention. Look at this black color, H1C, a 50-year-old man with a newly diagnosed type 2 diabetes with H1C of 8%. It was left for first 10 years at 8%, then reduced to 7% in the next 10 years. He did get the benefit, but the benefit was gain in life of 6.6%. That means the mortality benefit was 6.6%. In contradistinction, you have another person, 50 years, with type 2 diabetes with H1C of 8%. And from the very beginning, I repeat, from the very beginning, H1C reduced from 8% to 7%. See the mortality benefit, 18.6%, threefold greater risk reduction if you have early control. Therefore, dear friends, I'll come to a part of the UKPDS study. UKPDS is the compendium of type 2 diabetes. This is a part of the metformin trial. Metformin trial also showed that by a relative risk reduction, even after stopping the intensive treatment, and it continued. I'll show that you find that this is the first trial result, and you find versus conventional, and you find that legacy effect for any related endpoints continued even after you making it less tight control. And you see, it was not same as a combined therapy, 32% here, 21% after about 16.8 years. It was here about 29%. The legacy effect was 16%, 39 to 33%, and all-cause mortality 27%. Dear friends, this was not observed in this trial. Some other trial has shown legacy effect of blood pressure control, but to make a long story short, this was not observed in the blood pressure component of the UKPDS. I just very fast to tell you, it was a 144/82 versus 154/87. And you find that in the 10-year post-trial monitoring, the blood pressure was again followed up, and it was observed that the postal blood pressure values remained identical, but the 5 years BP therapies were no longer different. Same therapy was given, and you know, there was no legacy effect of earlier improved BP control on the diabetic complications. But I will hasten to add, some studies recently have also shown the legacy effect of BP control. Therefore, there is a new phase which is going on now. This UKPDS follow-up being extended to 40 years using NHS electronic patient record, and the objectives today are to determine whether improved care can give rise to the control, reduce longer-term risk of diabetes complications like death and dementia, and better identify patients at higher risk, and assess whether there has been improvement over time in health outcome, and quantify the lifetime health outcomes in this 40-year-long follow-up. Result will be available soon. Therefore, in the legacy effect learning, we found that despite an early loss of differences in the glycemic and therapeutic mortality, first during the 10 years post-trial follow-up, it was that we observed a continued reduction in the microvascular risk, an emergent risk factor for MI and all-cause mortality in the follow-up period. You know that fewer individuals actually achieve goals of H1C in contradistinction to lipid goal or blood pressure goal. So this is the objective that I'm talking about today. And you find it happens because of two things: clinical inertia, failure to advance therapy when required. You see people stay 5 years with a A1C of 8%, 10 years with another 7% from a study. Therefore, we do not advance the treatment, and also up-titrating monotherapy, here it is metformin, does not give the required benefit. One has to go, is a metformin dose response curve, one has to possibly go for the combined treatment. Therefore, can long-term glycemic control reduce the risk of cardiovascular disease? Answer is yes, if early and sustained glycemic control started early, that is before atherosclerosis is established, is beautiful. What are the cellular and molecular basis? I'll be very brief to tell you. It is because of the superoxide dismutase, the oxidative stress being ameliorated. It is because that the high glucose gets into the DNA of the patient, open conformation, and the DNA changes remains for a longer time. It is the advanced glycogen end products which gets imprinted in the cells, giving the metabolic memory. So hyperglycemia, oxidative stress, advanced glycogen end products are responsible for this. And this cartoon beautifully summarizes the metabolic memory in the type 1, where we have both the DNA changes, the reactive oxygen species changes, we have the changes to the vascular endothelial dysfunction. All this combined together gives rise to the last 7 minutes I have. I'll just talk about so what, a must do for all diabetic healthcare providers. So question today is how to intensify treatment with type 2 diabetics to provide this benefit consistently to keep A1C below 6 months. Dear friends, can I have your attention? Aim for a good glycemic control, that H1C of about 6.5 or 7%, which was safe and appropriate. Treat to achieve appropriate target H1C with the 6 months. If 3 months not a target, consider combination therapy, and consider initiating combination therapy or insulin therapy when H1C above 9%. Address underlying pathophysiology, including treatment of the beta cell dysfunction and IR. Use combination. We know the ominous octet of differential. Use appropriate treatment. Therefore, we need a pathophysiological approach and multiple drugs, as I showed you, in combination to correct the multiple pathophysiological defects. treatment should be based on the established pathogenic abnormalities and must be started early in the natural history of type 2 diabetes mellitus. Dear friend, therefore, hyperglycemia perpetuates beta cell damage. We have to take care of the beta cell damage, the damage of the glucotoxicity, damage of the lipotoxicity by taking care of that. And this is a recent study. I'll end with this quote from this study, that patients' lifetime history of glycemic control is necessary to understand why patients with long-standing diabetes develop complications despite excellent control, but later in the course of the disease. The association between the first-year glycemic control and the outcomes should be considered for formulating the public health and healthcare policies. This is very important. We are trying to impress on the PCDS what we need: the early first-year glycemic control at least. The young people and middle-aged people, 18 to 39, 40 to 63, they have been found to have very high H1C. We call it a missed opportunity. Lower periods of exposure to even 8 produces increased future risk of microvascular complication and mortality. Therefore, I will end by saying that findings of a relationship between the glycemic control in the first year being predictive of future events suggests the value that we have a great value for aggressive initial treatment, follow-up, and educational efforts. Thus, public health and healthcare policies should put a greater emphasis on achieving early glycemic control for the legacy effect as an avenue for improving lifetime outcomes. I end by saying stepwise increase in the drugs is not the answer today. We have to start appropriate pathophysiological treatment to control with the first 3 to 6 months effectively. Therefore, glycemia should be managed proactively to prevent it increasing over time rather than using a reactive rescue therapy, a reactive step ladder pattern. It's a major challenge as progressive hyperglycemia is a characteristic feature of type 2 diabetes mellitus, secondary to beta cell function, and must be anticipated. The type 2 diabetes legacy effect and type 1 diabetes metabolic memory effect probably reflect the complex biochemical and organ impact of hyperglycemia and the time scale. Remember the word time scale over which these changes occur. Although epigenetic changes may also play a role, it is unlikely that waiting until some years after the diagnosis of type 2 diabetes mellitus to minimize glycemia will fully recapture the benefit. Therefore, early, aggressive, appropriate control is the answer. Dear friends, I'm very happy to give this talk. I have 2 minutes left, so I can take up the questions whenever chairperson decide, now or later. In this 18-minute talk, I have tried to do justice, and I hope it was useful to all of you. Thank you very much.